There we go. Welcome, welcome. Good morning to Grand Rounds. I hope everybody's retaining some level of health. It feels like everybody's having brushes with sickness. So take care of yourself as Kerrie coughs. Yeah. Yeah. Okay. But she's not feeling sick. That's good. Excellent. So it's my pleasure this morning to introduce Kerrie Moreau. The topic that she's going to speak on today is digital medicine as an adjunct treatment for improving sleep and cardiovascular health in older adults with PTSD. Fascinating subject. And we've got, I'm going to go ahead and introduce her. And then I just wanted to make a couple of announcements. One is that after Grand Rounds, you'll receive an email with a link to the recording of the presentation. You'll also get in that email a link to an online evaluation. For those of you in the room, we have paper evaluations for you to complete. And we ask that you submit questions in the chat or in the Q&A boxes if you're on Zoom this morning. So Dr. Moreau is a professor in the Department of Medicine, Division of Geriatric Medicine at the University of Colorado, Denver Anschutz Medical Campus. And she's a research health scientist in the Geriatric Research Education and Clinical Center, also known as the GREC. She's at the Denver VA Medical Center and also serves as the director of the Cardiovascular Bioimaging Core at the medical campus. Dr. Moreau received a Bachelor of Arts from College of St. Scholastica in Duluth, Minnesota, a Master of Science from Ball State University in Indiana, and a PhD from the University of Tennessee in Knoxville, Tennessee. She completed a postdoc fellowship under Dr. Doug Seals at the University of Colorado Boulder. And her research evaluates the effects of sex and gender on cardiovascular aging, specifically on mechanisms by which change in gonadal function and sex hormones in women who are going through menopause and in men, how this alters cardiovascular and brain aging. Recently, Dr. Moreau has expanded her work to evaluate the effects of trauma exposure and PTSD on cardiovascular and brain aging. And we are so excited to learn from you today. Thank you, Kerrie.
Can everybody hear me okay? Great. As I cough here. Okay, thanks for that introduction, Dr. Levy. I just want to kind of put a big picture up here of what our research focuses on, and it helps kind of set the stage going forward. But as Dr. Levy noted, we study vascular aging, which is characterized by stiffening and thickening of the large elastic arteries, as well as an impairment in the vascular endothelium, which is that single layer of cells that line our blood vessels that serves as a protective barrier to maintain the overall integrity of the artery, but as well as prevent the buildup of plaque. And with the aging process, our arteries get stiffer and they thicken, and we start to develop endothelial dysfunction. This can lead to the rise in blood pressure with aging, as well as an increase in left ventricular mass, and contribute to cellular changes within the artery wall to initiate and promote the atherosclerosis process. This ultimately has an impact on the heart, where it can impair contractility, and then we can develop these secondary cardiovascular disorders such as high blood pressure, left ventricular hypertrophy, coronary and cerebral ischemia, and ultimately develop into heart failure, increased stroke, Alzheimer's disease, and dementia. And as noted, we do study the impact that menopause is having on cardiovascular aging, specifically on the role of changes in the sex hormone environment. As well as in men, we look at how changes in sex hormones and declines in testosterone contribute to this process. So this is the lens that I take on all of our research. And more recently, I say we're starting to study life now, because we see there's a lot of variability with the aging process. And so how do other factors that happen throughout life contribute to the cardiovascular aging process? And are there differences between men and women in this? And I attended a conference about a decade ago where they were talking about novel risk factors for cardiovascular disease in women, and they talked about post-traumatic stress disorder, or PTSD. So for those of you who are not aware what this is, it's a mental health condition that some people can develop after experiencing or witnessing a traumatic event, such as combat. We think of this in our veterans, natural disasters, terrorist attacks, sexual assault, but even having a serious health illness can cause PTSD-related symptoms. Caregiving can develop PTSD symptoms as well. And the symptoms that are most noted are feeling guilty, flashbacks, high suicide ideation, panic attacks, fear, not able to complete daily tasks, losing interest in life, depression, trouble concentrating, sleeping. So it's a really debilitating health condition. About 8.6 million adults will have PTSD in a given year in the United States. That's 7 to 8 out of every 100 Americans will experience PTSD at some point during their life. About 50% of women and 60% of men will experience at least one traumatic event in their life. And despite having less traumatic events compared to men, women are twice as likely to go on to develop PTSD from these traumatic experiences. And so if we look at the prevalence of PTSD in civilians, you can see here women have a 6% prevalence and 8% lifetime prevalence, twice that of what we see in civilian men. And then if we look at our veterans, it's the female veterans that have the highest prevalence of PTSD, even compared to our male veterans. The age group that affects us most is actually middle age. We actually see lesser prevalence of PTSD in older adults. This may be it's not being captured, or actually through different treatments, they are able to lessen the effects of PTSD. And so for an overview for my talk this morning, I'm going to talk about the association between PTSD and cardiovascular disease and Alzheimer's disease and related dementia risk. I'm going to focus on how the impact of sleep disturbances may be contributing to this risk, and then go into some of our research looking at some of the more underlying factors. How does PTSD affect cardiovascular health? We'll go back to our research focus of vascular aging, also touch on how it's impacting our autonomic nervous system, and then I will finish up with the latter part of a presentation on digital therapeutic interventions and talking about a clinical trial that we are doing with nightwear. And so the evidence for the association between PTSD and cardiovascular disease is overwhelming. This was first looked at in veterans, specifically male veterans. And those who have PTSD had close to a 50% increased risk of having a heart attack and a 45% increased risk of developing cerebral vascular disorders. It's not just in combat veterans, but we can look at first responders who have a high prevalence of cardiovascular disease. And this study was actually conducted in first responders as well as civilians down around the World Trade Centers following the September 11 terrorist attack. So first responders who had baseline PTSD, so they had it as part of their profession, they developed it, or if they developed PTSD over a 13-year follow-up period, they had a twofold increased risk of dying from cardiovascular disease. What I thought was really shocking, if you look at the civilians down by the World Trade Centers who had time-varying PTSD, meaning they developed it over this 13-year period, they had a 72% increased risk of dying from cardiovascular disease. This was the first study that looked at trauma exposure in women and looked at the association with cardiovascular events. This was conducted in the Nurses' Health Study, which has been going on, excuse me, for about 25 years, maybe longer. It's an observational study of nurses. And what they found was that nurses who had 4 or more PTSD symptoms, that was associated with a 60% increased risk of cardiovascular disease. And then just having trauma exposure, so no PTSD symptoms, that was associated with a 45% increased risk of cardiovascular disease. And when they started accounting for a variety of factors, if we look at behavioral factors, such as smoking, alcohol use, BMI, physical activity, diet quality, that accounted for 14% of that association between trauma exposures and cardiovascular disease. And then when they considered cardiovascular risk factors, such as high blood pressure, diabetes, as well as hormone therapy use and antidepressants, that accounted for about 50% of that association between PTSD symptoms and cardiovascular disease in women. There's also association between PTSD and the risk of dementia. This was a study conducted in veterans that was predominantly males. They were on average age of 68 years, and they were followed up over a period of 7.2 years. They adjusted for a variety of factors, including sex, race, ethnicity, education, income, medical, and neuropsychological comorbidities. And what they found is that overall PTSD was associated with a twofold risk for developing dementia. And when they broke it down by different subtypes of dementia and accounted for these factors, the association between PTSD and Alzheimer's disease and different variants of dementia remained at a close to a twofold increased risk. The study conducted out of the ADNI database had a cohort of male veterans from the Vietnam era. They were on average age of 68 years, and they looked at the association between post-traumatic stress disorder symptom severity that were assessed using the clinician-administered PTSD scale for DSM-5 or the CAPS-5. And they looked at the association between symptom severity and cognitive decline. This was a period of about 2 years. And they assessed cognitive function using MMSE. And then they also did the MoCA, which I had never heard of until a few years ago when our former president aced this test by saying person, woman, man, camera, TV. I'm a staple genius too. So after a year, and if we look at panel A, we have the total MoCA score. Panel C here is total MMSE score. And then panel B is the attention index of MoCA. And then we have the memory index in panel D. And this one here, they adjusted for a variety of factors, including some biomarkers of AD pathology. And what they found is that over this follow-up period is that those veterans that had the worst PTSD symptom severity had the greatest decline in cognition over time. And so what I believe is at the center of a lot of these associations with why it increases our risk for cardiovascular disease, as well as ADRD, could be sleep disturbances. It's a hallmark of PTSD. About 70 to 80% of individuals with PTSD are going to suffer from nightmares. And so if you have nightmares over here, if you're having frequent nightmares that are severe, can lead to sleep avoidance, cause sleep anxiety, contribute to sleep deprivation and insomnia. That can lead to irritability, cognitive dysfunction, just loss of daily functioning. You start coping with self-medicating behaviors such as alcohol and drug abuse. And it just can really wreak havoc on a person's life. And this cycle is perpetuated, and it doesn't get better until you intervene on this. And within the past year, there was a study that came out that looked at the association between possibly having nightmares and the risk for cardiovascular disease. This was a study conducted in veterans. This was a young veteran cohort, average age of 38. They served close to 2 tours in the military. It was predominantly male population. So we have the no PTSD group in the middle here, and we have the veterans with PTSD in the latter group here. And what they found is that in the group that had PTSD, you can see here about close to that 70% mark have nightmares that are severe and frequent. They also have higher rates of depression. They report poor sleep quality using the Pittsburgh Sleep Quality Index, or PSQI. And then they also were involved in moderate to heavy combat. And when they looked at the association between having frequent nightmares or severe nightmares, or the combination of the two, there was an increased risk for developing heart problems and high blood pressure. And even after adjusting for age, sex, race, smoking, depression, PTSD diagnosis, this association remained. And this led to an editorial asking the question on whether or not we should consider nightmares as an emerging risk factor for cardiovascular disease. And so studies have also looked at the association between nightmares and cognitive function and dementia risk. The authors of this study actually noted this association in folks who have Parkinson's disease. Apparently, they have a higher prevalence of distressing dreams that has been linked to dementia. And so what they did is they combined 3 cohort studies, one to get at a middle age group that had men and women, the MIDAS study. And then they had 2 older cohorts, one in women, the study of osteoporotic fractures, and then the Mr. Oz study, osteoporotic fractures and men study, and they combined these cohorts. They looked at the association between distressing dreams and cognitive decline and dementia by pulling out one item within the PSKI questionnaire that asks, during the past month, how often have you had trouble sleeping due to bad dreams? And this was from the middle-age cohort. We have those who never had distressing dreams, those who had less than 1 week distressing dreams, and then those that had one or more times per week of distressing dreams. And what they found was that there was like a fourfold, this is after adjusting for a whole variety of risk factors and behavioral factors. They found a fourfold increased risk of having or being associated with cognitive decline. And this association remained after adjusting for all these factors. And it was predominantly in men. When they looked at the older cohorts and the association between distressing dreams and dementia risk, those that reported one or more nights per week of having distressing dreams was associated with that twofold increased risk of dementia. And again, this remained after adjusting for a variety of factors, and it was predominantly in men. And so if we summarize this literature, we know that there's this association between PTSD and cardiovascular disorders that increase the risk for developing cardiovascular disease. At the center of this is likely disturbed sleep, which can lead to just maladaptive behaviors, poor activity. If you're not sleeping very well, you probably don't want to participate in physical activity. Use coping mechanisms such as abusing alcohol and drugs and not eating very well. And it can lead to these secondary cardiovascular risk factors that then can have an impact on the heart. But what we know is that this association between PTSD and increased cardiovascular disease risk, as well as ADRD, remains after adjusting for behavioral risk factors and cardiovascular disease risk factors, which suggests then that perhaps PTSD is having a direct impact on the cardiovascular system. So this brings us back to our research question in our group. And so the question that we've been asking is, could the increased cardiovascular disease and ADRD risk with PTSD be mediated by premature and or accelerated cardiovascular aging? And then again, are there differences between men and women in this process? And so these are all of the different systems that have been linked to the increased cardiovascular risk. We have vascular dysfunction, which I talked about earlier, has been linked with increased cardiovascular risk. I'll go over the evidence of that. Can also impact our immune system, can create a pro-inflammatory state, impacts our HPA axis, see higher levels of cortisol, and it can also impair our nervous system. And so I'm just going to review some of the evidence, including some preliminary observations from our work. And then this study here was the first to look at the association between PTSD and large elastic artery stiffening. They measured a cohort of Siberian older adults who were deported during childhood and who had symptoms of PTSD. And they compared arterial stiffness measured using the gold standard pulse wave velocity, which actually measures the pulse wave in a central elastic artery, such as the carotid, and in the periphery. You measure the speed of blood flow in this pulse wave, and the faster that pulse wave transfers to the periphery from the central circulation is indicative of stiffer vessels. And so we have pulse wave velocity on the y-axis here, and what they found is that those older adults who had PTSD had greater pulse wave velocity compared to age-matched controls, indicative of having stiffer vessels. When they looked at PTSD symptom severity, it was those older adults that had moderate to severe PTSD symptoms that had the highest pulse wave velocity, or the stiffer the vessel. Those who had mild symptoms were actually no different than controls. These data suggest then that older adults with PTSD have evidence of what we call an accelerated vascular aging process. Data from some of our work, we've looked at the association between PTSD and endothelial function, as those are those cells that line our blood vessel. And we looked at in a cohort of premenopausal women that were diagnosed with PTSD using the CAPS-5. They had to have trauma-related nightmares. They had to have poor sleep quality, have a PSKI of 6 or higher. The mean in our cohort is 12.5, so almost double that. I compared them to a group of premenopausal and postmenopausal controls from studies that I conducted in the past. And then although I didn't ask about trauma exposure and we didn't diagnose them with PTSD, what I did is I looked at those who had self-report sleep disturbances, who reported no no sleep disturbances. So that question 5H from the PSKI didn't report having distressing dreams and had to have a PSKI less than 6. So I assumed that they didn't have PTSD. All these women had to be healthy, so no evidence of cardiovascular disease or diabetes. They were non-smokers, had to have a blood pressure of less than 160/90, and we excluded for substance and alcohol use disorder. They could use marijuana. We excluded for sleep apnea, prazosin use, and beta blocker usage. We assessed endothelial function using a technique called brachial artery flow dilation. This involves ultrasound imaging of the brachial artery before and then following forearm cuff occlusion. This creates an ischemic response after 5 minutes. When we release it, you see an increase in blood flow that has a shear stress mechanism across that vascular endothelium that turns on signaling pathways within the endothelial cells to release vasodilators such as nitric oxide. So the healthier the vessel, the more vasodilation that you will observe. These are just some of the clinical characteristics of the population. It's a small sample size. Our groups in the premenopausal group are matched for age, although just to note that the women who had PTSD were about 5 years younger. BMI, there's no difference across the groups, although they did have a higher BMI. There's no difference in blood pressure. And I put here CESD scores, which is looks at depression. And you can see here, these women were overwhelmingly depressed compared to our premenopausal controls and postmenopausal controls. So if we look at the data here, we have flow dilation on the y-axis. We have our young premenopausal controls in black, women with PTSD in red, and then our older postmenopausal controls in gray here. And what we found is that the women, premenopausal women who have PTSD have reduced flow dilation, so they have impaired endothelial function, compared to premenopausal controls. They were no different than postmenopausal women who had reduced flow dilation compared to young healthy controls. And these data would suggest then that premenopausal women with PTSD and trauma-related sleep disturbances may have evidence of what we call premature vascular aging. And this was contrary to what I thought. I thought they were going to have some sort of resiliency due to estrogen, and that maybe it could mitigate the effects of having PTSD. But so far, I am wrong. And we also wanted to look at the association between PTSD and autonomic nervous system function. We can assess this by measuring the sensitivity of our baroreceptors. Those are our receptors that are located in our aortic arch in our carotid bodies that are sensitive to stretch. So if pressure goes up, the baroreceptors are going to withdraw, and we're going to see a compensatory decrease in heart rate, as well as a vasodilation response. If pressure goes down, we see our sympathetic nervous system fire to cause vasoconstriction. It just kind of helps maintain blood pressure on a beat-to-beat basis. If you have an impairment in baroreceptor sensitivity, it increases your risk for arrhythmias, orthostatic hypotension, and other cardiovascular disorders. And so we looked at the association between PTSD and cardiovagal baroreceptor sensitivity in premenopausal women, predominantly premenopausal women. We did have one male. Use a similar type of diagnosis for PTSD. We assessed it using CAPS-5. They had to have trauma-related nightmares. They were healthy, non-smokers, and similar exclusion criteria. So we matched the controls in the young. I have one male in this study, and as well as one male in the older cohort. And so similar to what we show for endothelial function, the young individuals who have PTSD have impaired cardiovascular vagal baroreflex sensitivity, and it's no different than what we see in older controls. As these data would suggest that young adults with PTSD and trauma-related sleep disturbances may have evidence of premature autonomic nervous system dysfunction. And because I'm interested in women's health, I had posed the question I tried to get funding for about 5-6 years ago through the VA, and trying to understand, one, do young women have resiliency? And then two, do women see maybe worse effects from having PTSD? Because you see a lot of similarities between menopausal symptoms and PTSD. Women who have menopausal symptoms suffer from sleep disturbances. You see an increase in anxiety, you see an increase in depression. So I thought maybe that could exacerbate the effects of menopause on the vasculature. And this study actually came out, I wish it would have came out about 5 years ago when I was writing this grant, because it would prove my hypothesis. But this study here looked at the effects of menopausal stage on PTSD symptoms in cohorts of premenopausal women, perimenopausal women, which is in this middle group, and then postmenopausal women, which is the latter group here. They looked at symptom severity, as well as various components of PTSD symptoms. We have hyperarousal, avoidance or numbing, and then intrusive. And across the board, what you see is that it's the perimenopausal women that have worse PTSD symptoms and higher symptoms of PTSD than pre and postmenopausal women. And it can go both ways. This study here looked at the association between menopausal symptoms and PTSD. These were midlife women who were categorized according to different types of interpersonal violence. So we have emotional, physical, sexual, and then those that had PTSD. And what they found is that the midlife women who had PTSD or who had exposures to these interpersonal violence, that they had, increased reporting of difficulty sleeping and worse menopausal symptoms, suggesting that yes, perhaps having PTSD can exacerbate the effects of menopausal symptoms and vice versa. And so does this have an impact on the vasculature then? These data were collected by Dr. Rebecca Thurston, who's at the University of Pittsburgh. I think these were from the study of women across the nation, or the SWAN study, measured flowmia dilation as a marker of endothelial function in midlife women, and categorized the women according to trauma exposure. So those who had none, 1 to 2, or 3 or more. And what she found was that those women that had 3 or more trauma exposures had the worst endothelial function compared to women who had no or 1 to 2 trauma exposures. And this was independent of a PTSD diagnosis, suggesting that yes, midlife women with trauma exposure or PTSD could have evidence of accelerated vascular aging. And so I want to spend the last part of my talk talking about digital therapeutics as a way to target cardiovascular aging in adults with PTSD. So there are a variety of interventions to date that have been used to target PTSD, particularly sleep disturbances. However, there are variable findings with cognitive behavioral therapy for insomnia or CBTI. Imagery rehearsal therapy has been shown to be very beneficial, and pharmacological treatments such as prazosin has mixed results. The unfortunate thing is that nightmare-related sleep disturbances are often resistant to treatment, and for those treatments that work, such as CBTI and IRT, there are implementation barriers, so access to care. So think about if you're somebody who lives rurally, you're not going to be able to access that care. And there's also just a lack of knowledge and trained providers who know how to do these treatments. Actually, I was talking to folks over at the VA, and I said, can you connect me with somebody who does CBTI? And they're like, no, we can't, because we don't have anybody here who does that. And then there's just poor adherence overall. And I found this to be astonishing, that there's been no FDA-approved PTSD therapeutic in nearly 20 years. And so this brings me to digital therapeutics. It's different than what we think about digital health, where we use telemedicine. And you don't have to have clinical efficacy, and it's not regulated by the government. We have what's called digital medicine, which are technologies that you can measure outcomes to improve health. So we have the remote patient monitoring or biosensors. You do have to show clinical efficacy for these, but they are not regulated by the government. Digital therapeutics are typically software that's developed to prevent and treat and manage a condition. Usually it uses machine learning algorithms and app-based technology, or virtual reality. These do have to show clinical efficacy, and they are regulated by the government. So before they become an approved digital therapeutic, it has to go through the FDA. And one such digital therapeutic that caught my attention, this was during the COVID pandemic. I'll never forget, I was sitting in front of my computer, November 9th, 2020, and I saw this headline: FDA authorizes a digital therapeutic for sleep disturbances in PTSD. I've been trying to get funding in this area, and I kept on getting a no from the VA because I have no experience in it, right? I don't study PTSD. And NIH has a mechanism called an R21. It's an exploratory grant mechanism. And I thought this maybe could be a way for me to just get some preliminary data in this population, so I can say, yes, I do have some experience in this population. So this caught my eye. The FDA approved this digital therapeutic called Nightwear. And what it does is it uses an Apple Watch interface with an iPhone. It's prescription based, so you can't download the app and put it on your phone. And it was developed by Tyler Skulsacek. He's based out of Minneapolis, Minnesota. He entered a hackathon when he was 13 and paired with some psychiatrists because his dad was a veteran and suffered terribly from PTSD and nightmares. So his dad was actually his guinea pig. He had 78 prototypes, so that it was the 78th that worked. And he paired with the company Nightwear for this to go to market. And what Nightwear does is the individuals wear it at night. It uses the biometric data that the Apple Watch collects, such as the heart rate sensor, the accelerometer, and gyroscope. So it's looking at changes in heart rate and in body positional changes. It takes all this information and calculates a sleep disturbance level known as the sleep index. And then over time, it analyzes the data. And if it thinks you're going into a nightmare because you surpass the stress index, it'll send a vibration to the watch of varying intensity and duration to interrupt that nightmare without awakening. And so it's important to know that Nightwear is not a standalone therapy for PTSD. It should be used with other therapies, such as prescribed medications or CBTI, and that it cannot be used in folks who sleepwalk or who act out their dreams. And so earlier they had pilot data, which allowed them to get the breakthrough device approval from the FDA, and then they completed a pilot study out of the Minneapolis VA. These were veterans with a PTSD diagnosis. Half of them were women. The average age was about 46 years, predominantly non-Hispanic white population. This was a 30-day intervention. They were randomized to either sham or active Nightwear, and they reported no other clinical demographics. They had to have a PSKI score of 10 or higher. Their mean was 14.5. They had to have a history of nightmares, so more than 7 in the past month. And they had to have a PTSD symptom severity using the PCL5 greater than 20. And they excluded for obstructive sleep apnea, which is comorbid with PTSD, current drug and alcohol abuse, use of beta blockers, prazosin, and if they had a high suicide risk. This little cartoon we developed just to show what it looks like when the information gets transferred to a portal. So those individuals that are in the active treatment, this is what it will look like. We have the heart rate on the left, on the left here, and then we have the stress index over here on the right. This particular individual, their threshold was 40, and you can see here by the triangles, that was every time that the intervention intervenes, so sending that vibration to the watch. And this is what it would look like in somebody who gets randomized to the sham. Their threshold is 50. You can see here they were above 50 and there was no intervention during the middle of the night. So what they found, they just looked at their primary outcome was change in sleep, self-reported sleep quality measured by the PSKI. So if you decrease your scores, it means you're improving your sleep quality. So we look over here on the left-hand side, the black bars are those that were randomized to active Nightwear, and then the sham is the red condition. Overall, both groups reported improvements in self-reported sleep quality. However, there was no difference between the groups in self-reported sleep quality. So it tells you the importance of that placebo effect. When they looked at individuals who were high usage, meaning they wore the watch more than 50% of the nights, they did actually see a difference between the two groups, where it was those that were randomized to the active treatment group showed the greatest improvement in overall self-reported sleep quality. It's important to note that they didn't look at the effects of night wear by age or by sex. And I pulled out this statement from this woman that has been using nightwear. She's a veteran, and she said since using the app, she's returned to being the person she was before insistent nightmares hijacked her personality. I have a 7-year-old son, and for 6 years of his life, mommy was bananas, mommy was grumpy and had no patience, she says. But no longer, even though she still physically has nightmares, she doesn't remember them and they don't bother her, and it gave her life back. And so we submitted that grant in February of 2021, so 3 months after the FDA approved this device. We were successful in getting the R21 mechanism, and we started our clinical trial. And this is a pilot study. Our goal is to just enroll we're targeting non-veterans because we wanted to keep a line so that we could do the study in veterans. They have to be 22 years and older. Why 22? Because that's what the FDA considers to be an adult. And they have to have a history of PTSD or current trauma-related nightmares. Our goal is to enroll up to 50, completing 42, 21 in the active nightwear group, and then 21 in the sham. And we want to have equal women and men. And we're struggling with that aspect because more women have PTSD than men. They have to have poor sleep quality. We're using a PSKI score of 6 or higher. And then we are excluding for cardiovascular disease, cancer, diabetes, uncontrolled hypertension, elevated acute suicide risk, and moderate to severe sleep apnea, current use of prazosin or beta blockers, shift work, narcolepsy. So we have a pretty strict inclusion-exclusion criteria. Our outcomes include vascular function and autonomic nervous system function. And then we added some outcomes of cerebral vascular function and cognitive function. And then we are getting objective and subjective sleep outcomes. We're assessing physical activity to see if we can see any changes in that with the intervention, quality of life outcomes, depression, PTSD symptoms, nightmares, et cetera. And then because I'm curious as to what's going on with the underlying biology, we're also getting some mechanistic outcomes down at the cellular level. So far, we've screened 434 individuals. I should say this is our last month, technically, of the study. We did get a no-cost extension, but we're almost done with this. But we've screened 434 individuals. 232 of those were eligible. We've consented 76. We've had 45 complete screening. We did have some that didn't qualify, and then we've randomized 34. This could actually be higher now. And we've completed 25. We've only had one person withdraw during the course of the intervention. I don't know what group they were in, but they reported that it was having an impact on their sleep. These are just some of the clinical characteristics broken down by the groups here. We have nightwear and then sham. You can see here equally distributed by sex, predominantly female, and then also by gender identity. So we have 9 that identify as women, 2 as men, and 3 non-binary. And in our sham condition, we have 9 that identify as women, 1 transgender woman, 2 males, and then 1 non-binary. You can just see here, they're normotensive. They're pretty healthy individuals, a predominantly young population, although we do have some middle-aged and older folks. And you can see here, based off their CAPS-5 and their PCL-5, they have severe PTSD symptoms. This is just a nightmare disorder index. And then I put here the depression score. So you can see here, they have high rates of depression. And so these were some data I had put together for the VA grant I put in. Reviewers asked for some preliminary data. And so just to show overall, the adherence so far is pretty good, about 76%. I mean, there is a range here, 32 to 100%. So we had someone that's worn it every single night. This is a 6-week intervention, although it takes a couple of weeks to get through all of our testing. And what we, similar to the previous nightwear study, we looked at changes in perceived sleep quality using the PSKI. And we have the nightwear group in blue here, and then the sham group in red. And similar to the previous study, we're seeing overall improvements in sleep quality in both groups, but more so in the group that goes to the active nightwear. And when I account for adherence, it doesn't change these numbers at all. And then if we look at the association between the those who reported better sleep quality after the intervention, it was those individuals that had the worst sleep quality from the get-go that reported the greatest improvements. And you actually see that in the sham condition as well. Like if we look at vascular function, this is our measure of endothelial function using flow media dilation. Black bars represent the baseline condition and red bars represent after treatment. You can see here the groups that go into the active group show an improvement in flow media dilation. We'll see if this is statistically significant at the end. But if we look at the change scores, they are different. And this 2% change that we observe is clinically meaningful. This is what we usually power all of our studies off of. So optimistic so far. And then I wanted to throw this in because I know there's some folks in the audience that are interested in cognitive function. And I was really just ecstatic about these data. We give out a variety of cognitive tests, including using the NIH Toolbox, which is a battery of various cognitive tests that get at memory, executive function. And I pulled out the total cognitive outcome. And this is a composite of various cognitive tests. And we have the nightwear group in blue here, the sham group in red. And what we're showing is after 6 weeks of nightwear intervention, an improvement in total cognitive performance in individuals randomized to nightwear. That's pretty powerful. And I can already see now the grant application that I'm going to submit to pursue this further and add some brain imaging studies to this. And so I just want to close here that, when we think about PTSD, we think about our veterans and our active military. My niece, who is an active military, actually, I found out over the holidays, is suffering terribly from PTSD. 2 years ago, she went over to Iraq. And first day on the job, and there was shelling going on, and her colleagues left her out there, and she was cowering, and she has flashbacks. She can't be out on the 4th of July. She's just really suffering terribly, and unfortunately, she's medicating through the use of alcohol, but doesn't think she can complain about having these symptoms. She's like, I'm fine, I'm fine, I'm fine, and clearly we know that she's not. We know that we have active wars that are going on right now, and folks, these are suffering from PTSD. We have mass shootings on a daily basis, and we know that this can have long-lasting effects on our mental health and PTSD. We have 2 people in our study that are survivors of mass shootings. One of those was in the Aurora theater shooting, and even though she wasn't in the theater, she was in the adjacent theater and doesn't feel like she should have these symptoms. But you got to think about, you heard it, you had to walk past it. And it's been a decade, and she's still suffering from PTSD symptoms. And then just, having these natural disasters. We had the Boulder fires a couple years ago, and there's reports of folks living in that area that suffered from PTSD symptoms. And then just the pandemic. We saw an uptick in PTSD symptomology. Our healthcare workers, that moral injury, it has an impact on you. And so, why is PTSD still overlooked? I think we have to start destigmatizing it and come up with effective treatments, because as I've shown here, it can lead to these chronic conditions with aging, such as cardiovascular disease and ADRD. And with that, I just want to thank my team, the nightwear team. We have Ryan Rosenberry, who was a postdoc that was supposed to lead this study. But unfortunately, as I show, we're predominantly women whose trauma has been at the hands of men. And so he unfortunately cannot be in the room for this. We have Brooke Thurman, who's our sonographer, that helps out. And then Lindsay will help out when we have multiple things going on. And then, of course, Claire Cox, who is the program manager, who came in with a background of studying PTSD and doing all these psychological assessments. So we couldn't do this without her. And then, of course, the image group, my colleagues here, and my collaborators within the university and at the VA, including Dr. Irene Schauer, who's our medical clinician on the study, Dr. Ryan Holliday through the MIREC, Michaela McCarthy through the COIN, and then we also use the CREST coordinators. And with that, I'll take questions. You want to use that? Yeah.
Give the floor to you all who has questions for Kerrie. And thank you so much, Kerrie. Fascinating work. You know, what's fun about Grand Rounds is you hear all these little snippets of people's lives and research, and then you get to see it in the bigger, you know, totality. Yeah, yeah. And I have a couple, but I'd much rather have you all ask Jen. You're gonna make me work for this, aren't you?
Nice presentation, Kerrie. Really interesting work. Like Kerrie said, it's nice to see it all come together after hearing bits and pieces. So you talked a lot about PTSD and sleep disturbance. What does the research say about just more general sleep disturbance that's not nightmare based? And how does that contribute to accelerated aging? Is there any work, you know, a milder kind of disruption of sleep essentially, and how does that potentially contribute? Is there any work in that area?
Some of my colleagues up at Boulder has looked at this in the context of vascular endothelial function and shows that those 6 or less hours of sleep a night have worse endothelial function. So there are some evidence there, but I don't think folks have specifically studied it in the context of aging, where we'll bring in like young cohorts, older cohorts to try to put it into perspective how much it's impacting the aging process. It's something that we're trying to do when we are doing our studies. We'll hand out the PhD questionnaire to kind of get at self-reported sleep quality. We're doing it across the lifespan in both men and women. And then we're trying to get some objective sleep metrics in this as well to see if we can kind of dial it in the type of sleep quality. So
Elizabeth.
can you hear me now? Hello? Okay. Okay, sorry about that. Do you want me to repeat that?
Okay. Thank you. I have obviously about a million questions of the other like trauma person.
Yeah.
I was wondering kind of a bunch of different things, but one is have you seen anything on the timing of trauma or like polyvictimization or repeated trauma, like kind of a dose response relationship? And in some of these pieces, because the people we're seeing have had trauma their whole lives versus like new onset trauma. And I'm just interested in.
We will look at that. We're collecting that information. I just anecdotal evidence from our current study, there are folks who had early childhood trauma, and then they were traumatized again as a late teen or young adult. And so there is that evidence there, that association that, you know, you see these repeated traumas. And so we'll count for that. We probably won't necessarily have the power in this pilot study. We're hoping to do this in the VA where we'll look at this as well, and we'll have a much larger sample size. And also this pilot study, we hope for it to serve as the basis for a larger clinical trial.
Maybe we should combine data.
I
'Cause
know,
I'm
you know,
tracking lots
when
of
I,
things.
when you used to be across the hall and I heard you were doing this, I'm like, oh, we really should talk. And
And on that topic, you had mentioned that the nightwear shouldn't be used without also complementing it with
yeah,
psychotherapy or.
we don't want to say it should be a standalone treatment. It could be, but so for example, if folks are being treated with the exception of prazosin in our current study. I mean, we allow them to continue whatever treatment they're on. A lot of them are on antidepressants or some other medication. But yeah, it would be great to do a clinical trial where you are doing maybe some head-to-head comparisons and then the combination of the two. So yeah.
Other questions, Lauren? Oh, geez, you're gonna make me work for this. Oh, golly, golly. Whoa, wait.
Sorry, I was gonna try to make you not run, but. So could you just talk a little bit more about like prescription apps generally, and if this is gonna be like something we see a lot of, or if you think this is like a niche area where it can be useful, and like, should we be worried about questionable regulation and all of those things?
I'll try to touch upon that because I am not an expert in this area. I mean, digital therapeutics are relatively a new area of treatment. For the nightwear, you do have to get a prescription from your PCP or psychiatrist. Right now, it's not recognized by insurance with the exception of TRICARE will cover it. It's not even covered through the VA. And so they need to have more studies to show its effectiveness before insurance companies will cover the cost of it because it is pretty expensive. It's about $7,500 for the kit. I know when some of our folks, after they completed it, don't know what groups they were in, because we even hear, Claire tells me she even hears it from those in the sham, like, swear by it, how it improved their sleep, and they don't care how much it costs, they want to get this. The company is pretty good with trying to work with people on this. And as far as the regulations and the data go to a cloud-based system, and there are regulations on that to help protect so that information doesn't get out. So for it to be able to even get approved by the FDA, you have to have, that is highly regulated. So I don't know is the answer to your last question about should we be concerned? I don't think so. If you think about, I mean, we walk around with our phones that is telling people a lot of information about us already, right? And I think there are more strict controls on the other side with these digital therapeutics.
Thank you for that. Sorry, there looked like there were a bunch of questions, but oh, okay. What do we got? And then Jacob, we'll go to you next. Have you done any research around activities or actions that might protect against the negative cardiovascular outcomes?
With regards, within the context of PTSD, this is our first study with the nightwear digital therapeutic. Hopefully we'll do some future studies. I'm an exercise physiologist, would like to see if exercise can slow down or reverse some of these effects or do a combination of the two. But this is literally my first foray into this area. And sometimes I feel like I have no business in this area because it's a troubling topic. But I have great colleagues to kind of help me with it. So.
I had a specific question. You had a sizable number of non-binary individuals
Yeah.
enrolled. Is that through intentional recruitment or network effect or
No.
self-selection? Any idea?
They just found out about it and wanted to be screened, and we didn't exclude for it. In fact, if I would have been smart early on, NIH had this mechanism, they're called administrative supplements to try to get at sex and gender effects. And I saw it too late. I saw it like a year after the fact, and you had to have 18 months left. But that would have been a great way of expanding out to look at this specific question of gender. But you can imagine if you're, non-binary or neurodiverse, how that can be impacting symptoms of PTSD.
This is maybe more a comment than a question, but this is super interesting. I wonder if this device could have an impact on patients with dementia with behaviors. And Elizabeth and I were texting throughout this with lots of questions, but because we were thinking about like use in the hospital for people with behaviors and increased sitter need, or in nursing homes where we know sleep has a big impact on dementia, and if nightmares and PTSD are a part of that. I don't know that that's a question, but
Yeah.
I find that interesting.
Yeah, I do too. And when I first started looking or seeing this association of PTSD and dementia, and I know I pulled Kerrie off to the side and I said, hey, maybe we should like submit a grant application in this. Maybe look at folks who have MCI, mild cognitive impairment. I mean, even in our folks who, for the most part, our folks have normal cognitive function, wouldn't meet the criteria of MCI, but they still, particularly if they're older, have trouble working it, even though you just hit a button to turn on the application. There are no other applications on the watch, and that's by mechanism. We don't want them to put any applications on the iPhone or the watch, so it's not interfering with it. So you'd have to have somebody else there to help, at night. Okay, you're going to go to sleep. So we're going to hit start on this. And they say that if you have problems falling asleep, that you shouldn't be doing any other activities, because otherwise that watch is going to fire, right? So you really want to turn it on when you're ready to fall asleep. And if you wake up in the middle of the night, stop the device, walk around. Folks who have PTSD get coached on what they can do to help them fall asleep at night. So do the whatever, get prepared to go to sleep, and then turn it back on. And then one of the questions that we got through the review process is, how is this impacting REM sleep, which we know is very important for our sleep quality, and that's where nightmares are going to occur. And we're like, frankly, we have no idea, because we've never done this before. And so we have been getting some objective sleep measures using some at-home sleep monitors, although we have to go a different route now because it got taken over by a company that wants to charge us a $80,000 subscription fee a year. So, but this way we'd be able to overlay the interventions and look at the EEG monitor to see if it is impacting REM sleep. So that's something we're interested in pursuing.
I'm going to ask you, and then I was hoping to introduce a few special guests in the room. Oh, one of our special guests left. Nope, they're all still here. Okay. Body Keeps the Score is a
Yeah.
really fascinating book, and they talk about EMDR and all these other therapies that have been shown to be effective. Do you have any comments on sort of those other treatments?
They do work. I don't know much about EMDR, but I know it has been shown to be effective, as well as TMS, and even the CBTI and IRT. The problem is just having access to those types of treatments, and then being, after you've gone through, they're usually like 6-week programs, for example, for CBTI and IRT, but then you have to keep up with it, right? And those of us, it's not the same, but who exercise, right? We're like, okay, I'm gonna start the new year, I'm gonna exercise. How many of us keep up with it, right? So these treatments are effective, but I think sometimes we just want that pill that we can take, or that quick fix to make it go away. And I think it's, something that they just have to just keep working on. And then, like someone said, what if you get re-victimized again or have another traumatic experience? It just fires that all up again.
Well, Kerrie, thank you so very much. This is fascinating, and I think the VA needs to fund you.
I do too.
Now. So, and I did want to just introduce a couple special guests. We have our GREC colleagues here. So Danielle Crawley and Eric Qualls. So thank you for coming. We're so pleased to have you. And I think we have Josh on Zoom. So we're getting just a beautiful team over there to keep building. And then in the back, we also have Abby Rolbiecki and special guest who I don't want to embarrass, but and so Abby's in town and will be fully in town starting this summer. So welcome and thanks for joining us so early this morning on your trip. So thank you all very much. I hope you have a great day. I think we're at time, and
See you next time.